Hi, everybody. My name is Tiffany. I am a graduate of the Rudy School of Nursing, class of 2018. I wanted to talk with you guys a little bit today about my current role as a nurse and what I do on a daily basis. So, I am an organ recovery coordinator for Tennessee Donor Services. I essentially help facilitate the recovery of organs for transplantation with recipients. So I'll tell you a little bit more about what is involved in that and different type of donation options. So there are really two types of donors. We have a donor that is that donates after a DCD, which is a donation after circulatory death. And then we have donors that donate after they've been declared brain dead. So to get to that point first, though, when you're working in the ICU nurse will call in a referral. Generally, the referral is with a patient who is a GCS 5 or less, and within an hour of achieving or reaching that GCS score, they are supposed to notify Tennessee Donor Services of this patient, and that begins our evaluation process. So when we're evaluating, it kind of looks like a shift change report almost. So we are calling and we call the bedside nurse who submitted the referral. And we let them know we're from Tennessee Donor Services. We just want to chat a little bit about this donor. We talk to them about their course of admission, when they were admitted, what happened, what's happened throughout the time that they've been admitted. Perhaps they had a regular routine surgery and then suffered a stroke and had a neurological change. So we're talking to them about their overall course of admission. We do talk to them about their past medical history, and then we talk a little bit about their neuro status and their brainstem reflexes. And when we're talking about brainstem reflexes, we're talking about cough, gag, corneal pupil reaction, withdrawing to pain, and then whether or not they have any respiratory drive, which is identified by either initiating breaths on the ventilator or breathing over the vent. So we talk to them about all of those things, whether they're on any sedation, if their vital signs are stable, or if they're requiring pressors for blood pressure support. We talked to them about their urine output and recent labs. We're looking at kidney function. We're looking at their liver function. We ask if there have been any imaging diagnostics done. For example, have they had a CT of the chest, abdomen, or pelvis? And once we've talked about all of that, then we ask them about the code status of the patient. If they're a full code or a DNR, has family made any decisions about either withdrawing pain or withdrawing care, or has the provider, has the medical team, have they talked about any brain death testing? And I'll get to a little bit more of that in a minute. So once we've discussed all of that, we then determine whether it's appropriate for us to go on site for an on-site evaluation of the patient. If the family hasn't made any decisions to withdraw care and they are the patient is still full code, full treatment, and they want to continue to pursue aggressive care, then we follow in the background for a little bit and continue to evaluate that person as a potential donor. If the family has made a decision to withdraw care, then we take that over all the information that we had just received and discuss with our leadership if this is a patient who has the potential to be a donor after circulatory death. If that's the case, then we would go on site with a family care coordinator and we huddle with the bedside nurse and the providers and determine an appropriate approach to the family. We look at whether or not that patient is a registered donor or not, and we get some of the family dynamics from the team. And then a family care coordinator will ask the family to step into a waiting room and talk to them about next steps. So I say that because we don't ever really want anybody in the medical team to mention donation, because sometimes it comes across as being abrasive or hurtful. And so our family care coordinators are very well trained in how to approach families about donation. And we always ask that if the family has made a decision to withdraw care, that the provider introduce our family care coordinator as somebody from family care who just wants to talk to them about the next steps. This decision that they've made is a difficult one, and we want to give them all the support that we can. So our family care coordinators talk to the family about the patient, what their hobbies were, what types of things they really enjoy doing, if they have family, what did they do for work. They talk to the family about funeral homes. Have they already picked one? Have they even thought about a funeral home? We talk to them about medical examiners cases. Sometimes the family doesn't realize that that patient is likely to be a medical examiner case. It depends on the situation and the circumstances of their admission, what brought them in. And so our team is really, really helpful and invaluable when it comes to having those conversations with the family, because oftentimes the medical team just doesn't have the resources available in that moment to have all of those conversations. So once our family care coordinator has discussed a lot of those different things, they will then kind of lead into donation, organ donation as an option. If the patient is a registered donor, that makes the conversation a little bit easier. If they're not, then sometimes it's a big surprise to family. And the family care coordinator, spends a lot of time discussing this with them and what this means and the legacy that they leave behind and the lives that they can touch. Losing a loved one is never easy, but if there's any silver lining that they can help save multiple lives, then I think that is something that really resonates with the families. So if the family consents to donation, then I, as the organ recovery coordinator, would start working with the providers to determine a plan. So when it's a donation after circulatory death, it's all very family driven. We let them drive when they want to withdraw care, and then we just make arrangements based on that. So a lot of times we will work up the patient, get a bunch of labs, and then we send out some labs to an outside facility, and these are called our serologies. So the serologies are the labs that we send out that look for hepatitis, HIV, a number of other tests, toxoplasmosis. We look at syphilis, and there are some other ones too, West Nile virus, sometimes Chagas disease. So it just depends on the age and if the patient had traveled anywhere. But generally, these are like the HIV, HCV or hepatitis C, hepatitis B, and then the toxo screen. So we send those out, and those do take a little bit longer to get back to us. So if the family is willing to wait for those results to come back, then we can begin running lists to see how many recipients there are that meet the same criteria as our donor patient. Once we have those lists run, we can start what's called allocating. So the allocation looks like a list is run, and you have recipients beginning at a sequence 1 all the way down to whatever sequence. It depends on the blood type and the whether or not that donor has any risk factors. And that list could be more than several thousand recipients long. When it's a donation after circulatory death, generally speaking, we can allocate kidneys and liver. In some circumstances, we can also allocate lungs and heart, pancreas, intestines. It really just depends on a lot of different things. And we just kind of go from there. So if the family is not willing to wait for those serologies to come back, because maybe they've been planning this for some time. They're really hurting and they just want their loved one to not be suffering anymore, and maybe they would just want to do this very quickly, then in that case, we would only be able to recover and allocate kidneys. And the reason for that is because we can take the kidneys back to our lab and put them on a pump where they have some pulsatile perfusion, and that can go on for several hours, even greater than a day or two, while we wait for those serology results to come back. And then we allocate once those serologies come back. But we cannot search for recipients until we have the serology results. So once that happens and we have consent, we have a time listed for withdrawal, and we have searched for recipients, we set all of the things in motion, and we look for a recovering surgeon to come in and recover the organs that we've allocated for. We do have a list of surgeons who will typically recover for us. Sometimes the center that is accepting an organ, they will send their own surgeon and their own team to come recover. It depends on the organ, it depends on the time of the withdrawal, and it depends on where that center is located. So once we have all of that set in place, we generally will go down to the operating room where everything has been set up for the operation, but we'll generally drape everything so family doesn't have to see the instruments in the operating room. We will generally do the terminal or palliative extubation in the operating room and then bring family in if family chooses to be there for the withdrawal process. There are some criteria involved if a patient's going to be a donor after circulatory death. In general, the patient would need to pass within about 60 minutes from their extubation time. And like I said, family is in there. And so it's really no different than if they were doing a terminal or palliative extubation at the bedside in the ICU. The difference is that we're in the operating room. So sometimes it can be a little bit daunting, or, even really just a little bit scary for family because it's such a sterile feeling and looking environment. But we always have a family care coordinator present. Generally, it's the one that's been working with them throughout the process. And our family care is there to support the family in any way possible. Sometimes we'll play music that the family has requested. And then once it's apparent that the patient has reached a cardiac death, that's confirmed by a declaring physician, and then the family is escorted out of the operating room. Family care will take them outside the operating room and sit with them in a waiting room and talk to them about everything and just do kind of like a debrief. Once that's done, then we have our recovery team come into the OR and we begin the recovery process. So the recovery process is very interesting. It's very fast paced in the donation after circulatory death because time is everything. And so once the recovery process begins, the organ recovery coordinator, like myself, will be in there. And if the team accepting the organ is not present, generally I would be the one to send pictures of the organs to let them know upon visual, the organ looks good. A lot of times they will request a biopsy. So once the organs are available to be biopsied, I'll send the biopsy sample to pathology. I'll walk down there, get pictures of the slide, and then also the report, send that off to the team that's requesting or has accepted this organ. And then they will usually say, yes, we accept, or sometimes they will decline for various reasons. And then we have to look for the next center to accept this particular organ. It can be very stressful. Like I said, time is everything. And so once you've reached cross clamp time, which is when all circulation stops, it's when the aorta is clamped above and below and circulation to the body has completely shut down. So once you've reached that time, you have what's called warm ischemic time. And that's the time that the organs are there associated or disconnected to all perfusion. So time is very, very important, and having real strong backup centers available is also very important. So you start working down that list if an organ is declined in the OR. But hopefully, more often than not, the organ is accepted as intended, and we can begin packaging the organ to have it either shipped to that team, or sometimes they will have a plane rather on standby at the airport, and we'll send a courier to that plane with the organ that they've accepted. So that's kind of what a DCD looks like. If a donor is declared brain dead, then that situation is a little bit different, because Tennessee Donor Services actually takes over as the provider for that patient. So those cases generally are a little bit longer, because we work to resuscitate various organs. And we use a lot of medications that ICU nurses are familiar with, but sometimes we use them in a different way. And as the organ recovery coordinator, I become the provider, where I am managing the care of that donor patient. So I will order labs about every 6 hours. A lot of times I am replenishing electrolytes, potassium, calcium. I'm managing their sodium levels. Their electrolytes are really important for donor patients, because if their electrolytes are off and that organ with an imbalanced electrolytes is transplanted into a recipient patient whose electrolytes are not out of whack, or not within normal limits, or their labs are within normal limits, excuse me, then that transplanted organ can cause issues with graft take. So we don't want anything to risk the transplant not going as planned, or not being as successful as possible. So it's really important that we continuously monitor their electrolytes. And we're also managing their blood pressure. So a lot of times we may have to start a patient on pressors, Levophed, vasopressin, sometimes dopamine. It really depends on the situation. Different blood pressure medications do different things for the donor patient. For example, I might start a patient on dopamine at a low dose if they've had some cardiac downtime, because their kidneys are suffering from that, and dopamine helps with renal function. While we are evaluating all of their organs for donation, there are some diagnostics that are done where they cannot be on blood pressure medicine. For example, if we are evaluating the patient's heart and we need to get an echo, bedside echo, we really need to do that without the patient being on any pressor support. So with the brain dead donor, we are managing their care, but we are also utilizing the knowledge and resources of the providers at the hospital. So we may ask them to do a bronchoscopy for the donor patient, so that we can get cultures from inside their lungs, from their fluid in the lungs, so that they can get cleaned out a little bit, because they no longer have a cough. They're not able to cough up any of the secretions, and we want to get those cleaned out so that we can have real good organ function. A lot of times we'll start with an echo at the bedside. If the echo looks good, depending on the age of the donor and the past medical history, we may have to take them to the cath lab to get a right and left heart cath. Like I said, with the lungs, we would do a bronchoscopy. We send out cultures from those secretions. We do a COVID test on every single patient at the beginning of the case. And then if we are evaluating them for lungs, we take a sample of the secretions from the bronchoscopy and we send that for COVID testing as well. If they are, depending on their age and past medical history, we may need to obtain a bedside liver biopsy. And then, of course, most of the time we end up needing to go to get a CT of their chest, abdomen, and pelvis. And what we're doing is really trying to do our best to evaluate all organs before we go to the operating room. And you start the recovery process, because nobody wants to be surprised with anything. This is a great opportunity for recipients for the teams looking for their recipients to see if the size of the organs are appropriate, if there's anything notable in the CT scan, if in the heart cath that the pressures are appropriate, that the coronaries are clean. So we're taking all of these different diagnostics into account, and then we start again looking for recipients. So each organ has its own list and its own number of recipients, and some recipients are on multiple lists. Some people need a heart and lungs. Some people need a heart and a liver, or lungs and a liver. And so the allocation process can be very complicated, but we work with UNOS a lot in determining who should get which organs based on where they're listed, which sequence number they're listed at. It is based on acuity. So the sicker the patient, the higher on that sequence list they're going to be. And then we start working with all of the different centers who have accepted organs to determine who's going to come recover those organs, what time works best for them. We really work with our families to determine if there are any time constraints, or if we have enough time to really locate a recipient and to schedule the operating time that works with the family. And then again, we set that OR time and we all reconvene. We check the certification for every recovery surgeon coming in. We set up for transport to and from the airport. And then once we're in the room, we have everything set up in the OR for each recovery team. So then again, it goes back to what I mentioned earlier. We're always alert and ready in case an organ is declined in the OR. We have to have our strong backups ready, because time is very valuable. And with the heart and lungs and liver, we don't have as much time, because once they're out, they're out. We can't place them on a pump like we can with the kidneys. So once the organs are accepted and packaged, and then they're on their way, and the operating room finishes up everything, and with our donor patient, we finish up and we send them to the morgue to be released to the funeral home. Or if they're a medical examiner's case, we work very closely with the medical examiner's office to provide them with information about their admission, as well as through the recovery process, and we'll release the body to the medical examiner. And then that's pretty much the end of the organ donation process as far as the recovery goes. We always let the family care coordinators know when the recovery is completed, so they can reach out to the donor families and let them know what gifts were recovered, and also to follow up with them with bereavement and after care. And then about 30 days later, the organ recovery coordinator, like myself, will send a letter to the various staff that were involved in the care of this donor, as well as the departments, and we let them know that which gifts were recovered. And we'll be able to sometimes include even, the heart went to a 43-year-old who is married with 3 kids and enjoys hunting and fishing, or whatever. It depends on what detail the recipients are able to provide us, but we do sometimes have pretty extensive recipient information for follow-up. Sometimes we really don't have anything other than the age and the sex of the recipient, but I think in most cases, having even that is worth everything for the staff who are drawing labs every 6 hours, traveling with their patient to the cath lab or to CT, or talking with the family at bedside. I think the staff are just as involved in the outcome of an organ donor than we are with Tennessee Donor Services. So it's always important that we update the staff as to the gifts that the donor has given. Family care will also send a letter to the family to let the family know about the gifts that were given. And they follow up with them quite frequently. And in some cases, later on down the road, maybe a year or so later, they're able to help facilitate sometimes the meeting of the recipient. And so the donor families and recipients do sometimes get to meet if that's something that is mutually requested. So that's pretty cool. Despite the mental and emotional toll death can take on any person, at the end of the day in this job, you know that you are giving hope to the donor families that their loved one will continue to live on with someone else, that they're not just completely gone, and you know that you've helped another person's life live on longer than it would have without the organ, without that gift of a kidney or a lung or a liver. And so the silver lining and everything in this job is really everything. It's the reward in itself. The donor families are so grateful that their loved one is one of the 2 to 3% of the population who can be an organ donor, and that they get to be a part of knowing that someone else's life is going to continue to live on. The job is very rewarding in that sense, but it can also be very taxing emotionally, especially because we deal with patients of all ages. We have organ donors that are very young, a month or 2 months old, and then we have organ donors who are in their 80s. It really depends on their overall health and what we discover through that evaluation process. So I wish that this was more in person so that we could have question and answers, because I'm sure there are lots of questions out there. But if you ever see me out there when you're working in the ICU or any of my colleagues, please don't hesitate to stop and ask. We're always interested and available to answer questions or provide some insight into this job. It is a tough job. We work 24-hour call shifts. So when you're on call from 8 a.m. until 8 a.m. And a lot of times when you are managing a donor at the hospital, you're the provider and you're there on site continually working for 24 hours. So it does get exhausting, but again, in the end, it's worth it when you know that you have had a direct impact in saving lives because of the ultimate sacrifice of your donor patient. So I hope this has been informative and interesting, and wishing you all the very best as you finish your last semester or semesters in nursing school, and keep your chin up and power through it. It is worth it in the end. And I just wish you all the very best. Thank you so much. And if you ever see me, feel free to reach out. I work in the greater Nashville area, from Jackson to Cookeville, and then from Clarksville down to Columbia. Sometimes I'll go and relieve counterparts out in the Chattanooga, Knoxville, Tri-Cities area, but I primarily am in the Nashville area. All right. Thank you all so much.